That's okay. This is sort of basic stuff. And then at some point we could maybe go to the unit and actually look at can you guys see my slides now?
Yeah.
Okay. Let me just put it in slideshow mode. So this is sort of a basic ECMO talk, and we'll cover a little bit of VV. If we have time, we'll cover VA as well. Um, so that's kind of the outline. So this is actually the first use of ECMO in 1971. I mean, it all comes out of cardiopulmonary bypass that was used for cardiothoracic surgery, and you can see like how much the equipment's evolved over time. This is much more complex, and I think this guy, he was in a motorcycle accident in the San Francisco Bay Area, and I think he might have survived despite ECMO, not because of ECMO, but they were treating him for sort of lung contusions. Um, and you know, it's an extrapolation of cardiopulmonary bypass, and it's been used in the peds world for a long time. But there was this study of it in adults in 1979 for ARDS, and back then they didn't really. The equipment was archaic. There were all these bleeding and cannulation issues, issues with you know, anticoagulation, and issues with you know, sort of hemolysis and things like that. And then in addition, they didn't really understand the concept of lung protective ventilation, so it didn't offer the same benefit, right? So half the benefit of veno-venous ECMO is that you can lighten up your ventilator support, and they would manage them exactly the same way. So you can imagine that this study was doomed from the start to fail. And it, you know, they put on I think 48 patients on conventional mechanical ventilation and 42 patients, and they actually did VA instead of VV. Most of the patients, all 9 patients died with pulmonary embolism. 6 patients with ARDS died, and basically they said it didn't increase your risk of survive or your chance of surviving, and then it was largely abandoned until about 2009, which was you know, the other pandemic, the H1N1 pandemic, and so you know, people were looking for things to do. There were all these ARDS patients across the world, and the ANZICS guys, the Australia New Zealand critical care guys, started using ECMO in adults again. And they had excellent outcomes with a 71% survival of these patients with severe ARDS from influenza. And so that got people's attention. Also in 2009, the Caesar trial was done, and that was a study done by Giles Peake in the UK, and it was looking at patients. So the way that the UK system for ARDS care works is they have these ARDS referral centers that offer ECMO, and then they have these more community-based hospitals. And if you were transferred to an ARDS center, your likelihood of survival improved. Now there's some critique of this study that says that you know, some of these patients didn't actually receive ECMO. 75% of them did, but maybe it was just the care at the ARDS center. But nonetheless, it was, you know, it generated more interest and strengthened the argument that maybe VV ECMO is not a bad thing. You know, it's certainly taken off in growth over time, and you can see, like, if you look now, the total runs for adults have actually surpassed, you know, kids, and so it's and like so per year, like these are a little bit dated, 2015, but even by 2015, adult runs outnumbered pediatric runs. Now these slides need to be updated, but Eolia has since come out as well. It was a study of severe ARDS, and patients were enrolled into either VV ECMO or conventional mechanical ventilation. And it was by definition a negative trial, although the patients had equivalent outcomes. And a lot of the patients in the control group got pulled out of the control arm, and they actually got randomized, and they ended up crossing over and doing ECMO on them anyway. And so it sort of diluted the effect. So it boosted the, you know, how well the control arm did, because they still did an intent to treat analysis on it. And so if most ECMO doctors interpret Eolia as a positive trial, although that, you know, that's not the way that the conclusion reads in the publication. So these are examples of different ECMO systems. So we primarily use cardio help machines now, and I'll show you those. But they're nice. They're small. You can travel to CAT scan, things like that. There's these older McKay Rotoflow machines where they have a kind of a control box, and then you can put your motor here, and then you hook a separate Quadrox oxygenator onto it, and they work fine. It's just different systems, but CardioHelp kind of dominates the market now for ECMO. And this is a very kind of simplistic diagram that I made for a review article I was writing on ECMO. And so basically you have your venous inflow, you have your pump, you have your outflow, and then the gas goes through an oxygenator, and it's essentially like a dialysis. So you have a sweep gas that runs counter current to your blood flow, so you can add oxygen and you can remove CO2, and then you have your arterialized blood flow cannula, which can either go to an artery or a vein, depending on whether you're doing veno-venous or veno-arterial ECMO. So these are just the basic components of the circuit. You know, I think historically people wanted to make circuits really, really fancy or and do all these different things. But I think over time people have simplified it, because the more bells and whistles you add to your circuit, the more risk you have for complications and blood leaking and air embolism and things like that. So this is what the pump looks like. It's a centrifugal pump. It spins round and round on these kind of rotors, and it entrains blood into it and then shoots it out. So you're primarily limited by preload in terms of what kind of flows you can develop, and so that's mainly determined by the size of your venous cannula. Afterload can have an effect, particularly in veno-arterial, like if they're really hypertensive, that can affect your outflow. And then if your preload and afterload aren't an issue, your RPMs really dictate what your output from the ECMO circuit is. So these are what the oxygenators look like. So Quadrox makes most of the oxygenators. This would be a separate, the one on the left here is a separate oxygenator. The CardioHelp, the pump and the oxygenator are built into one package, and so you buy the whole thing. So if you replace one, you replace the other. And this is what the inside of an oxygenator looks like. So, blood flow goes in, blood flow goes out, and the gas is actually flowing through these tiny tubes that are in this artificial material that's will allow gases to go through it, but it won't allow a red blood cell to go through. And so, you send the gas through these hollow tubes, and the blood flow is running between them, and that's how that's kind of what the inside of the oxygenator looks like if you cut it in half and look at it under a microscope. So I mentioned circuit rules, simple is better, and your cannulation strategy you need to think about before you cannulate the person. You're trying to figure out what are your goals. Like, does the person need cardiac support and pulmonary support, or just pulmonary support? If they need just pulmonary support, generally it's veno-venous ECMO. Now, a question comes up a lot of times about, well, the person's on a little bit of Levophed. That's very common in patients with bad ARDS because they're on a ton of ventilator support, and your RV's struggling, they're acidotic from hypercapnia. And so a lot of times if it's just a little bit of, a low level pressure requirement, you can put patients on VV ECMO and you'll see that pressure requirement melt away. If they're on rocket fuel, then you're probably going to end up putting them on VA ECMO. And then, or if the person's coming in with a primarily cardiac issue, then VA ECMO might be your best bet, or some sort of VAD type device. Like if it's purely an LV issue, we might put an Impella in that person. If they have biventricular failure, then generally VA ECMO is going to be your strategy of choice. And so you got to think about what you're trying to accomplish, and then and again, whether you need respiratory support as well. ECMO is going to help with that, whereas like if you put an Impella in, you're going to get no respiratory support. And VA ECMO will decrease your RV preload and decrease your RV afterload, because you're kind of sucking blood out and diverting it. It will decrease your LV preload, but it increases LV afterload. And we say no effects of VV ECMO on the RV in this diagram. It's a little bit of an oversimplification that the augmented delivery of blood to the RV puts a little bit of stress on the right ventricle and kind of increases its preload. So it's something to monitor when patients are on VV ECMO for a while, whether they're going to develop RV failure. So again, VV ECMO primarily respiratory support. I have some diagrams that explain better, you know, how it comes to be. A lot of times people are disappointed. They think you start VV ECMO in a patient with bad ARDS, and their SAT's going to be 100%, and they're going to be up and walking around. But in patients with really severe ARDS, that's not really how it works. And so, your institution has to figure out what your philosophy for VV ECMO is. I think there's some people that think ECMO is the future and that all severe ARDS will eventually be managed with ECMO as opposed to ventilators. But it isn't risk-free. I mean, there's risk for infection, hemolysis, bleeding, stroke, thrombosis, cannulation issues, etc. And the randomized control trial data isn't super strong yet. Some places use it strictly for rescue in patients that you can't perform lung protective ventilation on. I think we're probably a little more aggressive, and depending on our capacity and the underlying patient, age, et cetera, whether we're more like a severe or somewhere between severe and rescue. These are some typical indications for VV ECMO. We've been doing a lot of COVID lately because that's what's around. Although, pneumonia, aspiration, influenza, trolley, DAH. It works great for status asthmaticus. You can use it for BPFs to sort of minimize the amount of vent support. There's very few absolute contraindications. If you have irreversible lung disease that's like end-stage lung disease and they're not a transplant candidate, that is an important absolute contraindication. If they have multi-organ system failure that's non-survivable, that would be an absolute contraindication. Some old school relative contraindications: greater than 7 days of mechanical ventilation, particularly poorly done mechanical ventilation where they really beat the lungs up pretty badly, can be an issue. Bleeding diathesis, you can run patients without anticoagulation for a time. And so I had a trauma patient that had pulmonary contusion. She had an intracranial hemorrhage, an ICP monitor. She had a fresh XLAP and a recent splenectomy, but needed VV ECMO for pulmonary contusions, and we put her on, and we just ran her with no anticoagulation for a few days, and then started gentle, low intensity anticoagulation, and she did fine. And we've, so those are some examples of, it's not all of these contraindications are truly contraindications. This is an article that kind of supports what I was saying. There's this temptation in patients with fibrotic interstitial lung disease to think that, maybe they have a reversible process like a pneumonia or pneumothorax, and you're going to fix that, and they're going to, get better and come off of ECMO, and so put them on and treat the underlying issue, and then they'll come off. And it's generally a strategy that's doomed to fail. And so if you don't transplant patients with severe fibrotic interstitial lung disease that end up on ECMO, then they generally don't get off of ECMO. If they have a steroid responsive type ILD, like I've done an antisynthetase and she did really well and came off, but somebody with IPF or bad fibrotic NSIP, it's probably a bad idea to put those patients on ECMO if they're not transplant candidates. So kind of mentioned that already. There's different ways you can cannulate VV ECMO. We do a lot of fem because you can still ambulate patients. There's this kind of sense that that patients are more ambulatory with Avalon or Crescent catheters that are these dual lumen bicables, but there's no reason you can't ambulate patients with femoral catheters, and we feel like you can get higher flows and sort of generate better support. You can also do jugular cannulas. We've done that as well. So you can do femoral, jugular. There's different ways to do it, and all of them work reasonably well. This is an example of what an Avalon or the dual lumen bicable cannula looks like. So you draw blood out of your IVC and it goes into the machine, and then you return your kind of arterialized blood, and it's direct. You direct a jet out of the side of the cannula into the right atrium and try and deliver it into the right ventricle. And so that's something that's very not uncommonly used. So with VV ECMO, your goal is really adequate O2 delivery, and so there's a bunch of different ways you can achieve it. You can adjust the vent, although remember your goal is lung protection, and a lot of times we're kind of ultra lung protective, and we keep people's plateau pressures in the 20 to 24 range as opposed to accepting plateau pressures of 30. You can adjust your FiO2 on the circuit, your flow rates on the circuit, hemoglobin, sweep for CO2 removal. You can do things like if they're really maxed out on ECMO and vent support to affect O2 utilization, like sedation, analgesia. You can paralyze people if you really need to. You can control their temperature. And ultimately, if you can't support somebody adequately with VV, you can add another cannula and to make their flows higher, or you can add an arterial cannula and kind of directly deliver blood. This is a nice diagram that sort of shows you how you get sort of shunting. And so, you might take your patient that's got bad ARDS and what comes out and that the patient sees is a combination of what they get from the flow from their ECMO machine and what they're getting from their native circulation. And so in this patient, their post ECMO PaO2 is 500, but they're getting 50% of their blood flow that's 500, and the patient's got severe ARDS, and now you've lightened them up to lung rest settings, and so their PaO2 from that 50% is only 35, and because of sort of shunting, what you see in their pulmonary artery is a PaO2 of 64 and a SAT of 92%. So, it really drags down your oxygenation when you have this kind of mixing, but you get an acceptable SAT, and it allows you to lighten up ventilator support to a point where you're not causing tons of additional ventilator-induced lung injury. And as they get better and their native lungs improve, then it gets much, much better, and you can kind of wean their ECMO circuit. So this is a real case that we took care of here. We had a 24-year-old CF patient who got sinus surgery, then decompensated, and wasn't able to be supported on the vent. So she got placed on VV ECMO. She had a left IJ Avalon. Her hemoglobin was 10. She was on lung rest settings with a rate of 10, tidal volumes of 4 cc's per kilo of her ideal body weight, 50% in PEPA 12. On the circuit, she was getting 100% FiO2, 6 a sweep, a flow of 3.5 liters. Post pump gas, the circuit was working fine. Her PaO2 was 450, and then you check ABG from her, and her PaO2 is 55, and her SAT's 84. And the nurse calls you and asks, what should we do? And this is her X-ray. So what do you guys think? What would you do in that situation? She's SATing 84%.
You said if she has an Avalon, so that's a dual cannula?
Yeah, and you can see it here in the X-ray. So she had a left IJ Avalon.
Can we increase the sweep?
Let's see. I mean, her pH is 738 with a PCO2 of 38. So increasing the sweep would make her PCO2 go down. It would make her alkalotic, but wouldn't necessarily help you.
Does she need more flow, or can we optimize her hemoglobin?
Her hemoglobin was already 10, and she's flowing 3.5 liters, and that's about as much flow as you can get. So it's a little bit of a tricky question because you just want to assess for adequacy of O2 delivery. As I mentioned, maintaining adequate perfusion is really the name of the game. And so when patients are really have bad ARDS, you might have to tolerate SATs in the 80s, and that's okay. And sometimes we even tolerate SATs in the 70s. And so you can look at things like, evidence for shock liver, elevated lactates, look at their urine output and renal function. We don't know what a safe PaO2 is, but a lot of times we just tolerate SATs 80% and higher, and that's okay. So in this case, no change was needed. We looked for signs of inadequate O2 delivery and end organ dysfunction, didn't find anything, and then she eventually got transplanted and did fine. And she's probably 5 years out from transplant now. So again, early on, you may not get that sort of ambulatory ECMO that people envision. You need some time for recovery first. And so remember, this is just another diagram saying, that what you get and what the patient sees is an admixture between your ECMO and your patient blood flows. So what's the optimal vent management strategy in VV ECMO? The long and short of it is that nobody knows for sure. It's an area of sort of intense debate. I can tell you my own personal bias is sort of an open lung strategy with high PEEPs early on. And then you want to bring people's tidal volume down to something that's lung protective. A lot of times it's in the order of 4 to 6 cc's per kilo. I think plateau pressure is like 25 or less. I don't think you have to have a plateau pressure of 18, 20 to 25. We don't know if the delta P is what's important. We generally will lower their respiratory rate because, and you're trying to do things to minimize barotrauma. So you want them to not have tons of attalec trauma, but also not tons of like over distension and trauma on the alveoli from that. This is a study it's all retrospective data, but they found that in general, patients that were managed with higher PEEP early on had better outcomes. And it is true that like once you let the patient de-recruit, it's much harder to open. It takes a lot more pressure and energy to open an alveoli than it does to maintain it open. And so, and I think, really, really aggressive sort of ultra lung protective strategies, I think the patients don't tolerate quite as well. And so I'm sort of in the middle of the road camp, but you can get different opinions from different people. We try to trach people relatively early. We've done some proning as well, and there's some, and if they're not needing proning, like if they're too sick to mobilize, we generally will prone them early on because there's some benefit to that. But if they don't, if you can be more awake and they can mobilize, then we try and work on minimizing sedation, waking them up and mobilizing them. You want to make sure they're clearing their airways. A lot of times they need frequent bronchoscopies. You want to make sure they're not developing secondary infections. Control your volume status with diuretics, and introducing spontaneous breathing is nice to sort of mobilize the diaphragms, etc. In terms of weaning and VV ECMO, over time you're kind of decreasing your sweep and your FiO2, and if you get to a point where where they're on sort of room air through the circuit and a reasonable sweep, you can increase your vent settings to something lung protective and just clamp the gas line, and so that the blood circulating and they're not going to clot their circuit off, but you're not contributing to oxygenation or ventilation. So we call that a clamp trial. And so weaning in VV ECMO is pretty straightforward. You guys have any questions on VV ECMO?
Do you have any experience on this artificial lungs, and would they add anything to this VV ECMO? Or like
When you say artificial lung, what do you mean? Like Nova lung or A
Nova
lung?
lung, yeah, like
I haven't used Nova lung. We have A lung here. It doesn't. A lung is like a CO2 dialysis. It's a low flow thing. It's like cannulated at the bedside by an intensivist. It's a little bit bigger than a dialysis catheter. I think it's 15 French. There's an IJ and a femoral cannula you can use. They can remove CO2, but they don't really add any, because the flow rates are so low, you can't really add oxygen substantially. And so I think probably not a huge role as it stands right now. Over time, I'm not sure if, it may become more of a thing, or using, they call that E-core. So it's extracorporeal CO2 removal, whether people will use that in patients that have non-compliant lungs and sort of support their oxygenation with the vent and add E-core is sort of like ECMO light kind of strategy. So we have some experience, but not a ton.
got it. Thank you.
All right, well, why don't we talk a little bit about VA ECMO? It's for patients, again, that need cardiac or cardiopulmonary support. We have a pretty big cardiogenic shock program, so we see a lot of this. And you got to remember, again, ECMO is a bridge and not a destination. So a lot of times, these patients will come in with a big STEMI, they get stented, they're in cardiogenic shock, and your first question is, are they going to recover? But if they're not going to recover, you want to know if they're going to be a candidate for a more durable solution like a transplant or a VAD. And some of that depends on whether you have biventricular dysfunction and on all the sort of normal transplant stuff. Do you have social support? Do you have insurance? Blah, blah, blah. This is just a diagram. It's a fancy way of saying what I just said. In terms of contraindications to VA ECMO, a couple things that you would not do this in. Aortic dissection, you can't do VA ECMO. Severe aortic insufficiency would be an absolute contraindication because that blood is going the wrong way in your aorta and it's sort of so countercurrent. So if you have wide open aortic insufficiency, you're just going to flood the lungs and distend the heart, and it won't end well. Again, just like with VV ECMO, if you have end-stage cardiac dysfunction and you don't have a destination to transplant or VAD, then you really shouldn't do it. And then irreversible severe neurologic injury is obviously not going to get better with ECMO. So these are all different reasons for that you can use VA ECMO for. We probably do it mostly for cardiogenic shock, post-cardiotomy syndromes when you go in for cardiac surgery and you can't come off bypass. We've done it for life-threatening arrhythmia, ECPR. There are some places that have formal ECPR programs, like San Diego and Minnesota have big programs, and they do a lot of this and have much better survival out of the hospital cardiac arrest. Massive PE, we've done quite a bit. Hypothermia, I feel like we've done maybe one, but it works really well for that. Drug overdose, we've definitely done. Poisonings. You can use it for circulatory support for high-risk PCI and things like that. Septic shock, air embolism, anaphylactic shock. So there's a lot of places you can use it. pH, we've used it as a bridge to introduction of therapy in de novo patients or a bridge to transplant. So with regard to cardiogenic shock, if you have viral myocarditis, that's the best case scenario, about a 70% survival. We actually had a guy I took care of, not this week, but last week in the ICU that had COVID, and he had isolated myocarditis, and he came in with an EF of like 15%, florid cardiogenic shock, and he got pulse dose steroids, IVIG, remdesivir, and he recovered really quickly and came off ECMO and did great. Post-MI shock, about a 55% survival with ECMO. Post-cardiotomy is one of the worst outcomes, about a quarter to 25 to 50% survival. I mentioned ECPR. There's no clear consensus on candidacy. In general, you have to have a witnessed arrest, an age less than 75, and a presumed cardiac or PE origin, but the outcomes seem to be better. There's newer data coming out on this all the time, too. Septic shock's a little controversial. I think it has to be the right kind of septic shock. If you have just bad distributive shock, but your heart is banging away, in general, VA ECMO is not helpful. But in patients that develop a cardiomyopathy to go along with it so that you can augment their cardiac output, then it does seem to help. And whether you arrest it before, it kind of dictates how well you do. There's a bunch of ways to use it with PE. If they have very marked hemodynamic instability, you can do it before they code. If they have a contraindication to systemic thrombolysis and they're hemodynamically unstable, you can put them on and then sort of support them until they improve. If they have clot in transit, you can put them on ECMO and then use that as a bridge to embolectomy or percutaneous thrombin removal. Or if you need to get them to a center with one of these things, or you can do it as an ECPR. pH, it can be used as a bridge to transplant, or if you have a reversible insult, or like you come in as a de novo presentation. I think we've done like 3 or 4 of those now, where we started prostanoids and weaned them off ECMO after. So again, just like VV ECMO, you want to think about what kind of support you need, like how fast do you need it? Do they need BIV support, right-sided support only? Are the lungs okay? And that kind of helps you figure out what you want to do. And then your cannulation strategy, there are central cannulation strategies. It's mostly reserved for patients that are having cardiac surgery already. Otherwise, it's typically peripheral and generally fem-fem. There is, again, a way you can do axillary cannulation, and you can put like this Dacron graft on there. But most of the time, we just do fem-fem. Depending where your arterial cannula is, you want to pick a site for monitoring that's furthest away from that. So if you have a femoral cannula, generally your right radial artery is the best place to measure blood from, because what you're seeing in your right radial should reflect what your brain and your coronary arteries are seeing. You know, again, if you have a right axillary return cannula, the right radial would not be the right place to look, and so you'd probably check your left radial, because it could give you a false sense of security and make you think that you're doing better than you are. So again, just like VV ECMO, what the person's actually seeing is a admixture of their ECMO output and their native cardiac output. And with VA ECMO, you worry much more about regional variations, because you're delivering blood into the aorta and it's moving countercurrent. So you could have like a red lower body and a blue head, and so I have some pictures of that. So this is, you know, again, you're drawing blood out with your venous cannula, and then you're delivering it into the distal kind of like abdominal aorta. And so there's a condition called differential cyanosis or Harlequin syndrome or north-south syndrome. There's all these different names, and it usually happens if your heart starts to recover but you have crappy lungs. You pump all this deoxygenated blood, and then, you know, so there's this mixing point, like in the patient that has a native cardiac output, where your ECMO blood and your blood from your LV mix. And so as your cardiac function starts to recover, patients can get where they're kind of have hypoxic blood going to their important organs like their brain and their coronaries, whereas their lower body is better off. So you can increase ECMO support to overcome that. You can kind of correct their pulmonary issue and plus up their vent support, or you can put upper body arterial cannulas, or you can add a jugular cannula and put them on VVA, so that they, or VAV, where they have like venous with arterial and venous return, and it's essentially like being on VV and VA ECMO at the same time. So whenever you're managing VA ECMO patients, you want to make sure your flow is okay. And again, it's preload, afterload sensitive. You want to make sure they have a map. So just because you're guaranteeing them a cardiac output by, you know, whatever flow you achieve with your VA ECMO, your perfusion of your vital organs is linearly dependent on your map. And so in general, you want to add pressors to maintain a map greater than 65, or else you're going to have hypoperfused organs despite having that cardiac output. And they have a lot of reasons for hypotension in ECMO patients. Could be hypovolemia, blood loss, sepsis, sedation, postcardiotomy, vasoplegia. There's a number of reasons that can occur, and so you need to address that. And then increasing your ECMO flow can help your map as well. In general, I say maintain pulsatility. You want to maintain LV unloading. And so in general, if you're pulsatile, it means that you're emptying your LV. Some patients, you know, if their heart is really down, they won't have a pulsatile ventricle, and you have to do some sort of LV venting strategy. But if you don't drain the LV and you're delivering all this blood in the wrong direction, the LV gets dilated, and you can get aortic root thrombus, you can get pulmonary edema and hemorrhage, and you can actually over-distend the LV and get ischemia or infarct. And I've seen that before. So there's different ways to deal with it. If you can try to add ionotropes to make them pulsatile. A lot of times we just put an Impella in and we'll leave it at like P2, and we use that to decompress the LV, so you have some blood exiting the LV. There's ways that you can directly LV vent. This is like an apical cannula that goes through, you know, your chest wall into your LV apex and drains blood and directly ties it back into your venous return cannula. Some people use balloon pumps. I think they don't work that well. Or you could decrease your ECMO flows if you don't need the support. You also want to make sure you're getting adequate perfusion, so trending lactates. You can use your pre-pump gas as a surrogate for SVO2 in VA ECMO patients, not in VV ECMO patients. And then you can, you know, look at ABGs that are at a site distal to the, you know, distal to the return cannula. You also want to monitor for limb ischemia. I showed Ahmed this on Miss Ford, but you can take like blood off of your arterial cannula and put it in a catheter that's directed down the leg, and that way you can ensure there's some blood delivery, because these arterial cannulas can take up a lot of your femoral artery, and also the blood's generally going the other direction. And so if you have poor contractility and blood moving the other way in the aorta, it's easy for the limb to get ischemic. And so you want to do neurovascular checks on the side of your arterial cannula, and we generally put distal perfusion cannulas in everyone. How to best anticoagulate VV or VA ECMO is pretty controversial. There is an ELSO guideline on how to do it and how to monitor. You'll see places do all different stuff: 10A levels for heparin, PTTs for heparin, PTTs for bivalve, ACTs. When we use heparin, we usually use anti-10A levels. We've been using more bivalve with PTTs. I don't know that bivalve is superior to heparin. I think but it's just what they've been doing here. You can also want to make sure your fibrinogen's over 100, your INR is not way out, and so that way you can kind of dial in what you need. We usually try to keep platelets over 50,000. With ECMO, you typically get platelet dysfunction due to shearing your von Willebrand's factor. And you can also get some degree of platelet activation too, and so patients are at risk for bleeding and clotting. So things to think about. So this is just kind of a list of some of those complications I mentioned, and these are sort of troubleshooting guidelines for commonly encountered issues. How to wean VA ECMO is a little bit more of an art than a science. You can add ionotropes to kind of give the heart a little more oomph and a little bit more of a fighting chance. If you're going to turn down the flows, a lot of times you want to make sure they get a little extra anticoagulation. You don't want to turn the flow off completely, because you don't want it to retrograde flow on you, or you don't want your circuit to clot off. And you can kind of turn down though, and as you're decreasing your flows, your LV will have less afterload mismatch to pump against, and so your LV will generally look better. Now as you come down in your flows, your RV will oftentimes look worse because you're making it pick up more preload, and so you have to kind of consider both of those things. So any questions on that stuff, guys?
Yeah, Dr. Ken, could you go back to the side, I think it's 2 slides back, that looked at troubleshooting?
Yep.
So a lot of times, a lot of our patients, they're going really for severe hypoxemia. So what is your cutoff for like your flow for the VV ECMO? And do you tend to have a lot of issues with just like chattering when you bump the flow up really high?
So yes, this is more VA ECMO troubleshooting. Here, I'm going to stop sharing for a minute. If the patients are having issues with hypoxia, you're right, you can augment their vent a little bit, or you can augment your flows. But you're right, if you look at their negative pressures, then on like the pump, like how negative it is, you generally don't want that less than negative 100. And sometimes if the cannula is in their IVC and they're really dry, they'll kind of cough and suck down on their cannula, and then they'll lose flows. And when their flows cut out, they don't get the ECMO support and they desaturate. Sedation can help with that. Not over diuresing people can help with that. If they're really bad off, anticoagulation, paralytics can help. Sometimes we'll add a second cannula if we have a really hard time supporting them and can't maintain our flows, and so that's an option as well. So there's a bunch of different ways you can approach it.
Thank you.
Dr. King, one question about that pulsatility. When you mentioned that we add the Impella, it's going to be Impella added to VA ECMO or Impella to replace VA ECMO?
In addition to your VA ECMO, and then a lot of times when we decannulate the VA ECMO, we'll leave the Impella in place and support them with that for a little while, and then we'll take it out later on. But you can use it to empty LV so they don't get LV over distension in the context of their VA ECMO support.
All right. And I remember like there was an article in New England about a patient with COVID myocarditis, exactly going to the same situation that the VA ECMO was not providing the pulsatility and the ejection fraction was down. They end up doing a left side and right side impeller instead of that VA ECMO. How is the effect of this one different from a VA ECMO or the one you just mentioned?
I don't know. That wouldn't make tons of sense to me. I mean, like those will provide some support. They won't provide any oxygenation. There's not a ton of advantage to doing right and left side impella, and with impella support, as you crank it up, a lot of times you get significant hemolysis, and a lot of patients develop renal failure. Has been our experience. And depending on there's different kinds of impella. There's an impella like CP. You can only do uh, so much. Uh, like you can only get so much flow with like a cardiologist placed. There is an Impella 5.0 where you can get up to 5 liters of flow that's generally placed by cardiac surgeons, and they usually will do it sort of axillary through a graft. But yeah, I don't know why they usually with ECMO support you should be able to with VA ECMO support it's kind of the most aggressive form. So I'm not sure how they would have better flow with a right and left sided Impella.
Okay. Thank you.
All right, well, I think that'll do it, I guess.
All right.
Thank
Thank you,
you.
Dr. King.
No problem. See you guys.
Thank you.
Yeah, see ya.